That's it.
Hi, hi everybody.
That's brilliant.
I hope you hear me. This has been a real challenge for my brain, using 3 different systems and computers. So, can you hear me? At least someone type on the computer and kind of...
We can hear you. We can hear you.
Good.
We can hear you. Thank you, Anna. Yeah, carry on. Just carry on. That's good.
So thank you. Can you put the next slide, please? So that's me, Anna Mirelli, the neuropsychiatrist and liaison psychiatrist in Southampton General Hospital. And I will try to cover most of the things that we have been seeing in the hospital, but also I've been seeing outside with colleagues in neuropsychiatry and having conversations about how this has affected people with neuropsychiatric presentations. Next slide. So I just put some learning objectives as a way of trying to organize my thinking of how to cover the whole neurology and psychiatry in 30 minutes and how that is also related to the coronavirus. So I'm not going to cover everything. I'm just going to cover some of the things that have been happening and some of the new evidence of the things, and hopefully things that will help you on addressing or engaging in these assessments with patients. Sorry, there's some, I don't know if it's me doing the echo, so I have to put in speaker because otherwise I don't know what's going on. Shall I not put in speaker myself? And then you tell me if you hear better like that. I hope you can hear me from that. So next slide. So one of the things when I was doing this research, and one of the things that have been happening to all of us neuropsychiatry, is that everybody was kind of waiting for, we all know about the impact that has in psychiatry, and I found this quote from a historian of medicine that was describing this psychosis of influenza, and this was him doing a review of what was happening when we had pandemics in the past. And what he described, I like the way of this professional driven to the brink of madness and beyond by the nervous cycle of influenza. And I think, you know, we have a little bit there at this point, but now we have more technology. I think we have been trying to communicate with colleagues in China, with colleagues in Italy, trying to see what they were experiencing, so we could be ahead of the wave, isn't it? But I think this is quite an important thing, that this is not the first time that we are experiencing these changes in the way we traditionally see psychiatry. So next slide. So what happened when the coronavirus started, and we all trying to catch up with what we need to do next, there are a lot of case reports starting to be published. And I think that's the first thing that needs to happen, and it's the right thing to do. You know, we all want to know what's happening in other places and trying to see if there's any trend. That's what we do as medics, isn't it? Is there anything that we treat as a one-off, or is a trend here that we need to pay attention to how we organize service, how we organize ourselves, what do we do with the patient? So a lot of case reports started to be published, and I think most of you may know that actually the tightness for publication was also looser at that point, and people were more able to publish cases and reports. And neurology was reporting encephalopathies, encephalitis, Guillain-Barré, and stroke, you know, all of those things. But at that point, nobody knew, is this new? This is something that actually we are reporting because patients are having COVID and Guillain-Barré. Is this related to one to another? And psychiatry were reporting relapse of schizophrenia with confusion, which is not the typical presentation of schizophrenia, or more presentations of MS as well. So again, with all this case reporting, it's very difficult to know if it's something that is really changing or if something that we are reporting because we don't know what we are dealing with. So next slide. So one of the things that it is important to bear in mind, because there are many co-founders when you start to describe these things that happen in the context of neuropsychiatry as a presentation, but also in the context of ITU, in the context of an infection, in the context of many other things that could be affecting your results. So one thing is important that I think to describe that having delirium when you have an intensive care unit admission is very common. Actually, it's one of the most common, and in relation to the previous talk, there also patients are more likely to have PTSD after they have been in intensive care unit. And there are different reasons why. There could be that because they have periods where they cannot recall what happened because it was a traumatic event before coming here, but just the idea of only being in ICU is traumatic in itself for patients. And there are different types of delirium, can be hyperactive, of the mixture of them. So all of those things were also confusing the picture of is this because the patients needed to be more in ICU that we're seeing these changes, or because it's something related to the virus. Then the neurologist started to do some report for more cohorts of patients, and what they noticed is they were having patients, particularly with stroke, on the surface of consciousness, and some of them will have muscle injury. And muscle injury means that actually they were weaker, similar to Guillain-Barré, so all of those things that we're describing. And the patients who present with these neurological presentations, they tend to be at the beginning of the illness. So those were the things that are starting to be described more in groups rather than case reports. And I think at that point, psychiatry was trying to catch up, because one of the things maybe I should share with you that, and I experienced it myself, that everything was so focused on COVID respiratory syndrome that actually there was a point in the hospital I was saying, where are my patients? You know, why are we not having referrals for psychiatry or neuropsychiatry? Where are the delirium patients? That everything was hidden, protected, you know, separated in the intensive care unit or in the COVID wards, and there were not as many referrals that you will expect at the beginning. And everybody started to realize after me and some palliative care people and some other specialists were saying, well, where are our patients? And we realized actually patients were not being referred because all was about the survival from the respiratory and the COVID. So these are the kind of things that why I think we were a little bit delayed as well on starting reporting things on the psychiatric part, apart from the delirium. So next slide. So I put this slide here because in that context that the patients had delirium, they were intensive care unit, or very physically unwell with multi-organ failure. There was this nice report that looked at the different medications that were tried at that point for the coronavirus, and given that patients could present with agitation and they were unwell and they were confused, it gives a very nice timetable of how to combine the trial with psychotropic medication like SSRIs or antipsychotics or sedative medication. So I didn't put it there because it's quite a long list, but I thought as a reference for any of you who has any interest in this can have a look at it. And it's quite a nice summary, and it's on tables, and I really like tables. I like things that are easy to spot and to see how to access them. So I'm not going to talk much about psychotherapy, but if anyone wants to ask me something at the end, I'm happy to answer. But I think it's a completely different whole topic. So next slide. So what happened at that point? Well, we're trying to catch up on what happened with the psychiatric and neuropsychiatric patients. That delay in some ways of having to access the patients has given time to people to start doing systematic reviews and see what happened in previous pandemics, or in previous, actually it wasn't the pandemic, it was epidemics in these reviews that were done. And they look at systematic review, look at all the papers published, and then they did a meta-analysis as well in that thing. And they tried to compare that to what will happen now with the coronavirus, with the current evidence that was emerging. So they separated the study or the sample into 3 different stages of the illness. So the first one, when the person was in the hospital in acute setting, then post-infection, when the patient started giving COVID negative, and then after the patients are declared they were well, or well enough to leave the hospital or to be discharged from services. So interesting, as you can see, insomnia, memory, fatigue, depressive mood, is present in almost all of them. But at the beginning, memory and insomnia, which is something that you will expect if you're in a hospital and you're unwell, to be present there. But actually, without boring you too much, we do know that actually the effect of insomnia and all of those things can affect the long-term PTSD and depression. So this is kind of seeing the chain reaction between when the illness started to when actually you are discharged. And as you can see, like it was sent before, from this meta-analysis, about 30% of patients, more than 30% of patients had PTSD, more than depression and anxiety. So again, what I put in red is there just to see how memory, difficulties in sleeping, not understanding very well what's going on, the confusion can be a factor to end up causing PTSD in the future. And interesting, one thing I found from that study is actually people were going back to work after more than 2 years. So it took them a long time to be able to go back to work when they were unwell. What they didn't explain exactly the severity of the illness of these patients had at those points, so that would be an important thing to look into, how severely ill they were when in this cohort. And then from those, from that information from the past, what they're trying to do is, okay, with the data that we have now, what's happening, or can we anticipate what we need to do with patients with COVID? So the next slide. So now with the COVID, so at that point when they published this, they said that in hospital, the delirium was about 60% of patients, agitation was about 70% of patients, and the alteration of consciousness was also quite high. And most of the time when there were this fluctuation of consciousness were more likely to end up on people dying. So then they look at, from that data at the time of the discharge, many patients were having this executive function, planning, concentrating, and controlling behavior. And then at the time of the writing, and again, this is very hard, it was in May, so as you can see, we are having done a lot of follow-ups on these patients. This is more what happened in the hospital and at discharge. And in Southampton, for example, in the general, they are doing follow-ups at 4, 6 weeks, and I think 2 months and 4 months. So there's going to be some more data coming in terms of follow-ups. And there were also descriptions about people with hypoxic encephalopathy and encephalitis. The encephalitis is more the direct, or the hypothesis is direct effect of the virus in the brain, where the hypoxic encephalopathy, as you can imagine, is more related to the virus in the lungs and the multi-organ failure. So as you will expect, the quality of these studies that were reported were not great, but I think it's good. They're good enough to at least start having something to work on. So next slide. So with all of those things in mind, knowing that this historical information that has happened before, that patients tend to have more memory, insomnia, PTSD, depression, is this due to the neurotropic virus? Is because the immune response that we have, or is because the patient had received treatment that is neurotoxic, or is this reactive, or is that a combination of all of this? Or are we seeing, I think it was mentioned in the previous talk, are patients who are more vulnerable from transitioning from subclinical to clinical disorders, or worse in the pre-existing disorder? And I think those who have been in clinic, we see all of those in terms of worsening pre-existing disorder and transitioning. The PTSD, I don't know if we have measured too much, and also there has been a lot of work now when we identify patients with acute adjustment disorder, at least from brain injury, we do know that many of those patients develop PTSD, so early interventions are crucial. So maybe doing these early follow-ups is something that it may change or may actually help us in the development of PTSD. But anyway, these are all the reactive things. So let's start to look at the different possibilities of why we are having these presentations that it was described in previous meta-analysis. So next slide. So for the neurotropic virus theory, the first starts from, there are two things that I put in here, models on how to understand why is this virus end up in the brain. And I think one of the theories that I put here was from the respiratory team, trying to understand why patients end up in such a respiratory failure. And the autopsy of patients with coronavirus, but also experimental models, that we can see that the people and the animals have a lot of viruses in their brainstem. And the theory is that they could come through the nose, but they also could come through the lungs and then going upwards towards the brain. And that's one of the theories of how does this virus invade the brain. But from the respiratory perspective, they were not interested about the neurological consequences. They were interested about the respiratory consequences. But it's a model of how we can understand how this virus ends up entering the brain. So next slide. But then the other group look at from the enteric system. So you swallow some of these viruses, plus what it comes from the brain. And again, similar model, I think it was described before, the vagal nerve system, that actually you can go up and you end up into the brain. So these are different models. And the other thing is the cytokine storm that actually can break barriers and can make go to the bloodstream and from there go to the brain. So different ways of how the virus can get into the nervous system. So next slide. So to give more support to this theory that actually there is a correlation between virus and mental health, interesting, this paper was published in February, and to be published in February means that the researchers were doing this systematic review months before, so it came really a very good time. I don't think that this was reactive towards the pandemic, but actually it did come in a very good time of publication, where they were looking at they're looking at the influence of pandemia and the correlation with psychosis risk. Similar to what I said in the first slide of trying to understand why do we have these changes in presentation. And this paper really looks at the maternal risk of developing psychosis in the children when the mothers have influenza infection. So they look at many of these papers. As you can see in each of them, the relationship to psychosis, people will have delirium, dementia precox, as you remember this in the 1920s. Then they will have encephalitis, schizophrenia. So there are many terms that were used for what was happening during that time. So again, this is not new. This is something that we know that there is a correlation, that we're still struggling to understand how these two organs, let's say the lungs and the brain, connect with each other. How do they get to this? So next slide. So again, trying to understand, is this an effect of the virus or is an effect of the immune response? So if you go to the next slide. So you can see that these authors propose from the maternal perspective how the virus can actually get into the immune response and then affecting the response from the cortisol response, neuroplasticity, and the theory is all about neurodevelopmental theory of psychosis. That's from the maternal part, but then from if you have an infection, they added that other part. You can also have immune response not only in your brain but actually in your bloodstream that actually can change and disrupt your genetic expression and end up developing psychosis. This is a very simple scheme that we're putting here just to see where people are thinking in terms of neuropsychiatry, how you get from a virus to the brain to the behavior manifestations and phenomenology. So next slide. So with all of the things that we were reading and trying to figure out what's happening with the patients, we do have in liaison a group. It's a liaison email where not clinical, because it's specific about patient, but yes, difficult cases or difficult situations are put into that forum, and we support each other and give ideas and see what's happening. What was interesting that there were starting to appear apart from all of the things that we just described, the possibility of PTSD, the moral injury, people are starting to describe psychosis first presentation, and people who never had episode of psychosis before. It's something that started to become like a trend, and most areas were describing the same thing. And in Southampton, we have the same presentation as well. So next slide. From that, what I'm trying to see from theory to reality, sometimes about how we translate the research into our everyday clinical work, isn't it? So that's what I put that in there, that it's not just what the papers are saying, we were experiencing that. So with all of those things and with the description of what was happening in different areas, the neurologists and the psychiatrists did this surveillance survey. I think most of you must receive an email about trying to complete that. The college was quite pushing into having people participate in this. It's called Core Nerve, and it was in collaboration with the neurologists and other physicians as well, and trying to capture earlier on patients who have positive and not COVID positive and not, and the changes in presentation. I think again we are trying to understand, is this reactionary or this is related to the virus? So all of that data, if any of you have completed it, they ask you to put the presentation of the patient, not any specific data, presentation of the data, if you know if the patient was positive or negative, and then it goes into a long list into neurological and behavioral stroke psychiatric presentations, and that data was sent to the investigators, and if there's anything that needed to your name as the person sending was the only thing that was collected, not the patient. So then if they wanted to collect anything from the patient, you will have to ask permission and, all the ethical approval they need to get from there. But that was the first thing, was just a glance of what's happening on the ground. So I think it was a very nice and good idea. I don't know if anyone of you have completed. I think from us we sent 2 patients from the liaison, were both positive. So the next slide. So from that surveillance, what they have, and I think this paper is not published, published recently. When I did this presentation was in mid-June, and they were still in the review for the Lancet, but it's now published, and I just put here some of the findings. And interesting, the median age, as we have been hearing, is older people, older population. But as you can see, it's a wide range from 23 to 94. So this is something, again, it's been constant in the literature that the cerebrovascular events were the most common ones, particularly ischemic strokes, and some vasculitis. But again, this is a small sample after all, 153 patients. But it can start giving us a little bit more information of what was happening on the grounds. Then the second group were the altered mental state, that actually, this is a kind of very broad description, isn't it? But the majority of these patients have encephalopathy, and then some of them have encephalitis. And then the remaining, the third group, were the psychiatric disorders, and the majority of them, as you can see, were the new diagnoses. And among those, the majority were psychosis. And then you have some cognitive dementia and then some affective disorders. So I think this starts giving us some good understanding of, the majority of the patients had the stroke, and I think this is very much related to the inflammatory response. But then you start having other presentations that are related to encephalitis, and most of you may know that encephalitis, it has also combined with a lot of neuropsychiatric symptoms. And then the more pure kind of psychiatric presentations, but in this context, related with the neurologist. So that's one thing. I think it would be nice if anyone wants to read the whole paper. And I think they're still collecting and going a little bit farther after that. So next. So and then here I put 2 things that are very neuropsychiatry in some ways, because all of those things you can see the interface between a little bit neurology, but it can be really seen as very much psychiatry, apart from the things I described as stroke. But the functional neurological disorder this is something that we really work together with the neurologists. And as you know, we have, or actually has been classified that chronic diseases people were more vulnerable, and functional neurological disorders are chronic disease that actually does not have structural explanation. I don't like to say organic because I think there is an organic explanation, but not structural in the classic definition of neurology explanation for the neurological manifestations. This can be disorders of movement, seizures, and of course, patients with functional neurological disorders were worried about their risk of having coronavirus and having worse outcomes. So next slide. So Professor Stone from Edinburgh, who actually is a professor that does a lot of work with functional neurological disorders, did this video that actually I will invite people to have a look at. It's quite long, but I think if you have any patient with functional neurological disorder, it can be quite reassuring for them to watch it. About an hour long, but can be very reassuring for patients. So although it is described as a chronic FMD as a chronic disorder, does not classify as a high-risk condition for COVID. So in itself, what is described in itself does not worsen the outcome of COVID if the patient has it. However, because patients with FMD tend to have other comorbidities, and this is not uncommon that the patient have pain and have other comorbidities which for what they may be on medication, those things may actually make them increase the risk. And this is something that is about measuring these other comorbidities that the patient may have. Many patients with functional neurological disorder may have another neurological disorder. So it's not uncommon. So that's what he was trying to clarify and support patients with this. And one thing that we do know that stressors can exacerbate the symptoms of FMD. So one of the things he recommends in there, and I think we will all do to our patients, is that to be informed, but not to be overloaded with information, particularly because there's a lot of misinformation in the media and can be very anxiety-provoking. And that can be the reason why patients' symptoms worsen. So that's for the FMD. And the next slide. And then I put traumatic brain injury. And again, patients with traumatic brain injury usually have physical but also cognitive and emotional difficulties after the TBI, and therefore it's much difficult for them to comply to some of the restrictions, but also they may become more worried about going out and having to wear a mask. There's a very nice video that, again, if you have any patient with TBI, I would recommend. It's much shorter, for example, because it's for a TBI patient that actually the concentration is affected, that explains how to support them and how, it's for parents but also for the patients, how to go through these periods of the pandemic, particularly when there are so many restrictions. And so something to bear in mind, how to support patients with TBI. And talking about this, I think this is my last slide, so I wanted to share with you an experience that, because most of the things that we've been talking about here is what we understand of the coronavirus directly into the brain, or directly into the person. But one thing I've noticed, and I think it's an important thing that we forget about it. Like I mentioned at the very beginning, we were not able to access some of those patients because sedation was given, and the whole focus was about them breathing and the multi-organ failure, which is understandable, this is their priorities. But what I'm saying that sometimes we end up going too late to support the patients. And I just wanted to share an example of a patient who came at the very beginning of the pandemic, and he was admitted into the neurological intensive care unit after trying to commit suicide. And his injury was brain injury, but also spinal injury that actually made him be paralyzed from the chest down. And I think that the intensivist most worry was about the mobility and the difficulties in recovering from that. And the brain injury was somehow not put as relevant, and this had created, and again, because the patient was coming with a suicide attempt, the mental health problem is like, well, almost like he's done it already, so let's try to fix the spine. And without any intention from any of the practitioners, this coronavirus has created such a split into services, split, unintentional split, silo working, where everybody was focusing on one specific organ and one specific area, and people who were trying to think about the brain, because the brain injury nurse was not allowed to go in either. And then when I went to see the patient at one point, after weeks of the patient not recovering, I started reviewing the CT of the head, and I realized the patient had a serious, severe brain injury. So we needed to kind of start going backwards to do the brain injury rehabilitation, plus the section, plus everything that happened. And I give you that as an example of how the coronavirus can narrow thinking, and then it's becoming very difficult to do this holistic approach that we do in neuropsychiatry and liaison psychiatry. And how if we're going to think about doing things different to the future, is how we can join forces and work together, because patients have much better outcomes if we start from the very beginning in looking at the whole consequences. And I think the coronavirus has blinded us a little bit into many other things that are happening to the patient. And I do understand why that is, but it's more about how we don't lose perspective of the whole patient. So after that, I just wanted to put the whole thing into practice. The patient didn't have coronavirus. That was the other interesting thing. This was all about the patient who didn't have a coronavirus. It just happened to be in an intensive care unit where you had all these PPEs and you need to wear all of those things because it was an intensive care unit, and the approach and the assessments were restricted by the organizations, how things work. Anyway, I think that's my last slide. In the last slide, I did put links that I think you may find helpful for supporting patients with neuropsychiatric consultation, but also with FND and trauma, and there are also patients with epilepsy. There are a lot of other things, MNS, myasthenia gravis, or multiple sclerosis, so all of those patients, but I'm not going to cover the whole thing. I hope that you found this overview helpful. And that's it.
Thank you. That's absolutely brilliant, Anna. Thank you so much for that. Unless you have to disappear immediately, would it be okay if we move straight on to the next speaker, because we're running